Well, firstly, thanks very much, Claire, for the opportunity to speak today, and thanks everybody for attending. So as Claire said, I'm going to speak about researching the causes and prevention of type 2 diabetes, which is really the subject of our MRC Epidemiology Unit at the University of Cambridge, which came into existence in 2003. Before I launch into the detail of that, I think it's important to preface that by saying a little bit about what diabetes is and why it's important. So the word diabetes comes from the Greek siphon and refers to the issue that untreated people with diabetes have, which is of passing copious amounts of urine. And to distinguish the different subtypes of diabetes, Thomas Willis, a physician in the 17th century, identified the sweet taste of urine of patients with diabetes mellitus, which gives it its name, and which distinguishes it from diabetes insipidus, where the urine is much more diluted and a totally different condition. And that sort of clinical stratification of disease continued into the 20th century with the discovery 100 years ago of insulin, which allowed different subtypes of diabetes to be further distinguished. And a former secretary of the Medical Research Council, who was in place at the MRC for 20 years, Harold Himsworth, wrote this seminal paper in The Lancet in 1936 about the distinction between two different types of diabetes. One, type 1 diabetes, which is characterized by absolute insulin deficiency, and type 2 diabetes, where the problem is more of relative insulin deficiency in the face of problems of insulin sensitivity. So there are two major types of diabetes, and I'm going to focus on predominantly today on type 2 diabetes, which is accounts for 90% of cases in the UK. And diabetes is a multi-organ disease, but in type 1 diabetes, the problem is primarily of destruction of the beta cells in the pancreas, which produce insulin, and insulin is the hormone that acts through its receptor in various tissues to control the uptake of glucose into cells. So type 1 diabetes is an entirely separate disease. It has different causes and different treatment, and I won't speak any further about that today. But what I'm going to concentrate on is type 2 diabetes, where there is relative impairment of insulin production, but the primary defects are normally sensitivity of insulin being diminished at the end organs, which are primarily the liver, the muscle, and the adipose tissue. So why is it important? Well, it is rising in prevalence, and that prevalence in the UK is increasing steadily, driven primarily over the last 20 years or so by the rising prevalence of obesity in this country. And that means that the number of people with diabetes in the UK has more than doubled in the past 20 years. And in 1996, there would have been 1.4 million people who were diagnosed. By 2019, there are 3.8 million people. And diabetes matters to the NHS and to patients because it accounts for 10% of NHS expenditure, and much of that expenditure is about dealing with the consequences of the disease. And so the next slide gives images of some of those complications. So if you were squeamish, perhaps look away, but the microvascular and macrovascular complications of diabetes affect the heart, so it's a major cause of coronary artery disease. In the bottom left-hand corner, it's a major problem in relation to the kidney, and it's a major cause of end-stage renal disease. On the top right, it's the biggest single cause of non-traumatic lower extremity amputation because of vascular and neuropathic problems. And in the bottom right, it can give rise to retinopathy and maculopathy at the back of the eye, and around the world is the biggest cause of preventable blindness in working age adults. Now, the real positive over my clinical career, since I did diabetes in clinics in guys in the late 80s, has been the massive improvement in the way that we organize care and improve outcomes for people with diabetes. So fortunately, these complications are less common than they used to be, but are still obviously a major issue. I want to speak less about care and prevention of complications and more about what causes the disease itself. And we'll start by thinking about what explains differences in risk between populations and then between individuals. So if we look around the world, our prevalence in the UK is around 5%. So on this figure, which is a little old now, we'd be comparable to the US wide. But what's striking for an epidemiologist is these prevalence rates are so extremely variable. So there are some populations where the disease is very uncommon, and these tend to be traditional living populations like the Mapuche Indians in Chile. But at the other extreme, there are some populations in the world where the prevalence of diabetes approaches 50%. And you just have to stop and think for a second. 50% of people in a population have a disease which is associated with all those complications I just showed, and gives rise to at least a 6-year reduction in lifespan. So these are very major differences, and there are a number of different hypotheses that might explain these differences, but one of them was called the thrifty genotype hypothesis, the suggestion that some of these populations, like the Pima Indians, are populations who would have historically had periods of food scarcity and then food abundance. And in those periods, genetic predisposition to being able to store fat really effectively would be a survival advantage, but that becomes a disadvantage in times of food abundance. But the molecular basis for that hypothesis really remains to be unraveled. And to date, there really isn't a very clear explanation of what's underlying these population differences in prevalence, and it's a major unknown for the future. We have made some progress, of course, both in thinking about this and other issues that I'll articulate in a minute, because of massive progress in the last 20 years or so in identifying the genetic underpinnings of diseases like type 2 diabetes. And that arises from a combination of things, the combination of new technology, which has got cheaper and cheaper, which can then be applied on a mass scale to find the susceptibility of loci for particular diseases. And that usually involves massive international collaboration. And the field has really changed drastically over the last 20 years. So on the top right is an illustration of what's called a Manhattan plot, for probably obvious reasons you compare to the bottom. So each of the dots on there is a single test of an association of something called a single nucleotide polymorphism with a disease. So there now would be 30 million dots there describing the likelihood of association. And there are 22 chromosomes listed there. And you can see that the bigger chromosomes, because they're ordered and the chromosomes are numbered according to their size, the bigger ones on the left. And the big peaks that you can see are points of association with disease. So these are loci where there might be genetic variants that are more likely to be associated with somebody having a disease than not. So this has been applied to the diabetes itself and the quantitative traits that underlie it, particularly obesity and insulin resistance. And the single biggest peak for type 2 diabetes is in a gene called TCF7L2. What I want to talk about today is some of the value of understanding this genetics for individuals and populations. And to do that, I'm going to focus not on genes for diabetes in this case, but genes for insulin resistance, which are critical to underlying the condition. So we discovered a genetic risk score which has 53 of these variants in, and therefore you can put people into fifths of the population according to how many of the variants they have. And then you can plot the hazard ratio or the relative risk of somebody going on to get diabetes. So the comparison group here is 1, and this group here are the top 20% of people who are enriched with these genes for type 2 diabetes. And you can see they have nearly 40% increased risk, which is highly statistically significant. But the very interesting phenomenon I wanted to highlight is that you'd think that they would be overweight and obese, but what they have is a very interesting pattern of obesity. And if you look at the leg fat mass on the left-hand side here, you can see in the population, the top quintile, the top 20% who are at most risk for diabetes have the lowest amount of leg stored into their. And this is a manifestation of a phenomenon whereby the issue is really not of just overall obesity, but an inability or relative inabilities to store fat safely in safe deposits like the leg. And that leads to an overspill of fat into areas where it really matters, like the viscera and the liver. So what does this mean for our science? Well, one of the things we could do is work within our institute with colleagues like David Savage and Steve O'Reilly, pictured at the top right-hand corner here, to try and understand the mechanisms underlying that. And what we've been able to do in collaboration with them is to link back some of the top genes for insulin resistance in that score to the degree to which the adipocytes, the cells that are part of the fat tissue, the degree to which they differentiate if you have defects in those genes. And you can see that all these, the gene expression lines up with the amount of fat in the legs and with the diabetes risk at the bottom. Now, I'm not going to spend a lot of time today talking about these sort of mechanistic work, but I want to talk a little bit more about the implications of the genetics for individuals and populations. And I start with individuals. So one of the hopes, I think, of this sort of discovery and the investments that we're making in the UK in more sequencing is that we'll be able to take a disease like type 2 diabetes, which is not really a single disease, but then be able to break it down into different subtypes. And the hope is that those subtypes might have more targeted or personalized treatment that is more effective. And here is a real example of that. So here's a patient who I saw in the clinic who's got sent up with poorly controlled type 2 diabetes, despite losing 35 kilograms of weight and doing more than 10,000 steps a day. So this person was sent up with a GP letter that implied they possibly weren't trying hard enough, which is really unfair because this person was working as hard as they could to deal with this problem. And if you compare them with a person of the same age, sex, and overall level of obesity, so their BMI is the same, what is really striking is the red, which is the color map code for fat. These are on DEXA scans. So normally we have a lot of subcutaneous fat, as you can see on the person on the right. If you look on the person on the left, they have no redness, no fat being stored in their legs whatsoever. So this person has a form of fat storage abnormality. It's not caused by any of the classical mutations that cause lipodystrophy. It's probably caused by an accumulation of those genetic variants that I've just shown you before. And I think our future science will really hope to discover these subgroups and hopefully in time target therapies more effectively, because this person probably needs very specific care and they need to be distinguished from people with typical type 2 diabetes in our clinics. So what about the implications for populations? Can we look at how genetics, that genetic predisposition and behaviors, how do they work together and interact? Well, for that, you need to have a very large population-based study, and you need to have a population-based study followed up over a long period of time so that new cases of diabetes develop. And that means you had the ability to study people and characterize their behavior before they became diabetic, which is crucial. So I've been fortunate enough to lead a study of that type within the EPIC Europe study, which is a 10-country study across different parts of Europe, including 2 centres in the UK, in Cambridge and Oxford. It's very large. It had nearly 500,000 people at baseline, and it was followed up for a long time. We accumulated 4 million person years of follow-up, and within that found 12,500 incident cases of confirmed type 2 diabetes. The advantages, we had stored blood from everyone at baseline and the data on diet and physical activity. But the critical thing here is that people were different. So it had exposure heterogeneity. In other words, the dietary behavior and the physical activity was not the same in all individuals, because epidemiology thrives on difference between people. If everyone's the same, you can't work out what risk factors are. So it's good in the study that you have people from Sicily, you have different diet to people from Tromsø in Norway. So what did we find? Well, in terms of quantifying the importance of physical activity, this is a forest plot where you're looking at the estimates of relative risk for the individual centers and countries. So on this plot, a relative risk or hazard ratio is the risk in the exposed compared to the unexposed, and it's being categorized here per unit of physical activity expressed in what is equivalent to 20 or 30 minutes walking a day. So something that's a protective factor would have a hazard ratio less than 1, or something that was an adverse risk factor would have one that's over 1. So the summary estimate at the bottom is 0.87, which means that for a difference in populations equivalent to 20, 30 minutes walking extra per day, that would be associated with time with a 13% reduction in risk of type 2 diabetes. So that's extraordinarily powerful message, because the risk estimate is quite large. It's very certain because this is a big study, and the difference that people would have to make in order to achieve this benefit theoretically is relatively small. We'll return later to thinking about how we achieve that, which is a different matter. So in terms of diet, worked with my colleague Nita Free, who's led lots of this work, and I'll just give you one example because it pertains to the discussion about what we do about the issue later. And that example is about studying the relationship between sugar-sweetened beverages and risk of type 2 diabetes. This is one of many foods and nutrients that we've studied, but it's one that may have policy relevance. And in this paper, we reported the overall estimate per difference in people of drinking an extra can of Coke per day. And you can see that the summary estimate across different studies was about a 25% increased risk when you don't adjust for adiposity, and probably similar when you adjust for adiposity and take other issues into consideration. So that's a major difference in risk for what is a relatively small difference in the exposure. We've also integrated understanding not just about behaviors, but about developmental factors which are crucial to the risk of type 2 diabetes in later life. So alongside the thrifty genotype hypothesis that I mentioned at the outset, there's a complementary hypothesis that about the thrifty phenotype, that how babies, the weight with which they're born and how they grow in the first years of life and how we develop in childhood is crucial to adult diseases like type 2 diabetes. And one sort of salient time period is the point at which we go into puberty. So this is an analysis from Interact looking at the age of menarche. So this is in girls. So this is puberty timing. And the y-axis is the hazard ratio, or this risk of diabetes. And what you can see is that there's really, compared to age at menarche at 13, there's no difference in risk in having a later age at puberty, but there is a very steep increase in risk in those who have an age at puberty which is earlier. And that is in part driven by childhood obesity. So if you adjust for obesity, it goes down, but it's in part not. It's partly driven by other factors. And the very interesting phenomenon is around the world, the age at puberty has been declining very steeply, particularly in some developing countries. So this is a phenomenon that is not just a marker of childhood obesity, but it's interesting in its own right. And there is a lot of work on unraveling the mechanisms behind that, which is led by my colleagues Ken On and John Perry. But I wanted to speak a little bit about genetics and type 2 diabetes risk. So we studied 49 variants that were associated with the disease, and per standard deviation of a genetic risk score, there's a 40% increase in risk. So what does that mean? Well, across the different countries, they all line up. So the risk is the same in all the different countries. But what about if you look by different factors, where it's the same between men and women, doesn't differ much between those who have and haven't got a family history. But interestingly, it does differ by the level of BMI at the outset in the study. And the risk is much higher, relative risk per genetic risk score standard deviation is much higher in those who are thinner at baseline. So the naive conclusion would be, if we only knew about genetics, we could look amongst those who are thinner and find those who were more likely to get diabetes. But that is looking at things on a relative risk phenomenon. And when we come to prevention, it's not relative risk that matters, it's absolute risk. So if I flip it around and show the same data but on a different scale, here you're looking at genetic risk going from left to right in different quartiles. So the people here are at most genetic risk. And then I've stratified it by those who are obese in black, overweight in blue, and those are normal weight in red. And what you can see is that whatever your genetic risk, it's really the level of obesity that's driving this cumulative incidence of type 2 diabetes. So if a country decided, for example, we're going to put a threshold here and treat or offer prevention to those who are above this line, you'd offer it to everyone who's obese, but you wouldn't offer it to anybody who was at a specific genetic risk unless they were obese. So that the genetics is very interesting, and I think it will play a major role in our mechanistic understanding and in subdividing a disease like type 2 diabetes into different subgroups for targeted prevention. But the sort of naive thought that it will enable us to target prevention at the moment, it needs development as an argument, because it's not quite so straightforward. So I want to move to talking about can type 2 diabetes be prevented, because this is a very positive story. Firstly, there's a lot of undiagnosed diabetes around. The line for diabetes on a 2-hour glucose is 11.1, and in the past, around 4% of people had prevalent but undiagnosed diabetes. So it can be detected by screening, and we've had a major program led by my colleague Simon Griffin of trying to evaluate the benefits of that, which I won't go into today, but to summarize, there are benefits of early detection of diabetes, which we have really implemented now in the UK. But there are a subgroup of people who have pre-diabetes, and in this study was around about 17%. So can they benefit from early preventive intervention? The answer is yes. So this is the famous diabetes prevention program in the United States, where people with pre-diabetes were randomized either a placebo or the drug metformin, which reduces glucose levels, or a lifestyle intervention. And you can see that the lifestyle intervention halves risk of progression from high-risk states to diabetes, a very positive message. The critical question is, how do you take that trial and move it from can diabetes be prevented to how should it be prevented in the real world? And here you come across the problem that you need to think about the difference between what's measured in a trial, which is efficacy, and what is measured in the real world, which is effectiveness. And the problem about trials is how they're lost in translation. So Trials don't tend to be worried too much about the reach of the intervention. They tend to focus, for obvious reasons, on individuals at high absolute risk. And you have this active follow-up in trials for endpoints like diabetes, which actually increases the absolute risk compared to passive follow-up. And real-world applications of interventions tend to lead to dilution of the intensity, so you get less effect. So how big could that gap be? Well, here's an example. So this is a trial in the US where they rolled out the results of the DPP to the Veterans Administration in a program called MOVE. And if you compare people who participated in that, there was a 20% reduction in risk. And if people did it in an intense and sustained way, this lifestyle intervention, there was a 33% reduction in risk. So you could say, great, it's really effective. 33% is good. It's not quite 50%, but it's really excellent. The problem lies in who was asked to participate. So they offered this to 1.8 million people. 13% of people did it at all, and only 1% did it in an intense and sustained way. So at an individual level, those 1% of people will all benefit and they'll get a 33% reduction in risk. But at a population level, that will be diluted and the effect will be reduced. So it really depends on the lens with which you look through this. Is it worrying about the individuals or about the effect on the population? So that means we have to think about absolute risk. So in all of these trials of prevention, they think about targets. So the 5 targets are having a normal BMI, doing physical activity, reducing saturated fat in the diet, reducing total fat, and eating more fiber. And in the Finnish prevention study, the risk if you didn't do any of those targets was about 9 per 100 person years of follow-up, but it dropped to 2 if you achieved 5. So that's a massive drop, big benefit of the preventive intervention, but it's in people who are at higher risk. So what does it look like if you look in the general population? Well, it looks the same, but the risk levels are different. So instead of being 9 per 100 here, it's roughly 7 or 8 per 1,000. So the risk is some 10-fold less, but the gradient is still the same. And this is data from our EPIC Norfolk study. And in that study, if you met all those 5 behavioral goals that I spoke about just now, not one person went on to get diabetes. So the risk messages and risk reduction strategies are the same whether you're focusing on high risk individuals or the whole population. So the question is, which strategy is better? And to think about that, you need to think about what you're trying to do. Are you worrying about the individual or the population? So if you worry about high risk individuals, you could focus on people who have certain characteristics, and that would be a small percentage of the total population and a small percentage of the cases. They would be at high risk, and it would make sense to those individuals in terms of this column, numbers needed to treat, because the absolute risk reduction would be quite large. But the column about populations is this: the impact on the population attributable fraction will be quite small. So the strategy that makes a difference is focusing on making small changes in lots of people, because that has a big potential to impact on the population level and the population attributable fraction. It doesn't make much sense for the individuals because they don't make, the risk is low and their individual benefit is quite small. But when those small individual benefits are amassed across a whole population, that's the strategy that has the population impact. So this is really an illustration of what Jeffrey Rose talked about, is how that as a complement to high risk prevention strategies, we need to think about shifting the whole population. The small differences in lots of people gives rise to big population risk differences. So Jeffrey Rose said it was possible. What we've set out to do over the last decade or so is provide the evidence base that underpins that. And that means moving away from thinking about individuals and thinking about attitudes and preferences about diet and activity at the individual level, to thinking much broader than that about what are the determinants of behavior at the societal level and how do we seek to change that. So when we think about most evidence for interventions. We have a very linear approach. We take observational evidence, we develop an intervention, we do a pilot trial, then we do a definitive trial, then we synthesize that evidence in a meta-analysis of trials, and that eventually leads to policy action. So in the case of the diabetes prevention program, that has happened. And in the UK, we have a national diabetes program being rolled out as a consequence of policy action, which is excellent. And we have applied that approach in other intervention spaces. So this is just another example from Esther van Schlaus in our unit, who's done this for linear approach of developing and evaluating interventions for things like a school-based physical activity trial. That works there. But what about for populations? You might want to try and shift everybody's behavior by making England more like Copenhagen, but you can't randomize cities or to be more like Copenhagen. So the linear approach that works for some forms of intervention doesn't work for whole population level interventions. So you then need to do natural experiments, a totally different approach. So a decision was made to invest in the country in cycling infrastructure. And then my colleagues, David Ogilvie and Jenna Panther, have led a natural experiment of what then happens and can show that there are changes in prevalence of cycling in the intervention towns compared to matched and unmatched comparison towns and cities. So that's an impact on cycling, but we'd like to say, well, what does that do for health? And you can't directly observe that. So alongside this form of natural experiment, we need to invest in public health modeling. So this is work, and it's an example from my colleague James Woodcock, who's done a modeling study for what is the impact on health of efforts to increase cycling, like the Boris Bike scheme in London. And so this combination of natural experiments and public health modeling is really an important area for development. The other important thing that we have to appreciate is that the evidence base and the way we accumulate that evidence is different for public health. So at the bottom, there's a different model. So what happens is we take the observational evidence, we inform the policy development, but an early thing is policy action. It's not the end point of a process like it is for the more linear interventions. It's a much earlier decision point. And then after that, we work out whether it can be assessed and do a natural experiment and synthesize the evidence. There are many examples of this. I give you just one, which is we contributed evidence about fiscal interventions for dietary change to the House of Commons Select Committee in its session in 2014-15. At the time, no politicians wanted to know, but that evidence was there. But really, it wasn't our evidence. It was our evidence then complemented by pushes from people like Jamie Oliver that probably led George Osborne to introduce the sugar levy. So the policy action is informed by observational evidence, but then that leads to an ability to evaluate it. So my colleagues, Martin White and Jean Adams, are leading a national evaluation of the soft drinks industry levy, here exemplified by looking at how there have been changes in the content of sugar in foods that actually precede the actual implementation of the sugar tax, and indeed in some instances precede the announcement of the sugar tax. So I just want to close by saying something about how we should prevent diabetes around the world. And the major issue is that there are 600 million people with type 2 diabetes around the world, and 80% of them live in low and middle income countries. And the continent in the world with the fastest increasing rate of type 2 diabetes is Africa. And the challenge here is that we can afford better care, organized care, and we can afford individual approaches to prevention. In continents like Africa, that is a major threat to sustainable development if the money has to be found to treat the complications of the condition and treat our way out of prevention. which is why I think it's really important that we have established a global diet and activity research centre to take some of those messages about the evidence base for upstream prevention and try and support sustainable prevention of NCDs in low middle income countries, and particularly countries in Africa. So I think this is a major challenge for the future. And with that, I'll close with my conclusions. I think what I've tried to argue is type 2 diabetes is a clinical manifestation of a pathophysiological problem, but really the other way of thinking about it is as a public health manifestation of a societal problem. And we are struggling with the economic costs of it. We can afford a combined approach to prevention that has high risk and societal interventions. But the real challenge is in low middle income countries where it's a threat to sustainable development. And a different approach to prevention is required. So I've been fortunate to work as part of a fantastic MRC supported institute in Cambridge, but most of all, I'm fortunate to be part of a really brilliant team who've enabled all this science. So thank you very much.